Now we come to the last session, and that is on bladder cancer. May I invite the chairpersons, Shelly Hukku and Satyanker Gupta, to please come over here. Our moderator is Dr. T. Raja. Please come over. And the panelists are Amol Akhade, Nilesh Lokeshwar, Lalit Mohan Sharma, M.V. Chandrakant, and Pooja Gupta. Amit Blood could not come, and Sohail, I think his father is unwell, so he's not come.
So, good morning, ladies and gentlemen. So, this is the last session of the day. And we all know that the urothelial cancers are poor cousins of breast and lung cancer. And they happen in elderly, so not much attention has been given, and cisplatin and gemcitabine has been there for a long time. But with the development of, immunobiological parameters, we are now going to ICIs and ADCs and other agents. They're trying to gain pole position. But we should realize, and the statement is true for all the new developments, that guidelines are in one place, and we have a large gap to fill between what guidelines are and what is the real life practice, real world practice. And in urothelial cancers, we have to understand that they happen in elderly people, they have morbidity, and the availability and affordability of novel agents is a question. So, this will have two presentations, and I would request Dr. Satyanker to introduce the.
So, speakers are Dr. Amol. Speaker is Dr. Raja. Moderator is Dr. Raja. Panelist is Dr. Amol, Dr. Nilesh, Dr. Amit Bhatt, Dr. Lalit Mohan Sharma, and Dr. Suhail is not come, and Dr. Chandrakant, Dr. Pooja Gupta, and myself. And Hukku sir is also. Thank you so much.
Yeah, thank you, chairperson sirs, and thank you for this wonderful opportunity. I must thank the organizers, OBTO, Amish, and Purvish, Parikh, and for this meeting in the scientific committee. Over the past years, they have really taught us how to read between the lines in all these. That has been the cream of these series of meetings. So it's a privilege to be part of OBTO at any point. And today it's just the urology here, couple of papers. And as was pointed out by the chairperson, the treatment landscape for urology had stagnated for nearly 25 years. With platinum and then the doublet, it really took a long time for the next jump to come. Until in 2017, you had the pembrolizumab data in cisplatin ineligible patients, and then came one of the most blockbuster data set, that is in 2020, where maintenance Avelumab came after the induction with a doublet. And in the year 2023, two important data sets have emerged. One is the Checkmate 901, in which Nivolumab is added to Gemcis, and the Enfortumab data, Enfortumab plus pembrolizumab, EV302. So that's why this discussion has come. So my first question to, this has been the experience with the platinum containing doublets. They definitely do have a good disease control rate, but then eventually all of them quickly progress, and once you reach the second line, there were very little to offer, and there was a lot of frustration at that point, but the prognosis for whatever you do was always poor. That's what, and the median overall survival was somewhere around 13 months. So can we now say that in 2020 and 2023, that first-line chemotherapy alone is no longer an appropriate strategy? Dr. Amol, I'll begin with you.
Yes, I agree. That alone should not be an appropriate strategy in a fit patient.
But Chandrakant, you have any second opinion on that or?
Something like that has to be done.
Lalit sir?
Yeah, very true, sir. It is not alone sufficient, and we need to have a like monitoring and then stratify the further treatment. But alone is not sufficient.
Okay. So then comes the next question on a day-to-day practice. This is very common. In all of us, first look at the patient and then look at what am I going to do? What is the doublet? Is it going to be cisplatin, carboplatin, or no platinum at all? So this is very well known. I mean, everyone thinks through this pathway. But then if you look at this data set published in 2020 or 2022, 90% are eligible for some platinum. But then a larger kind of a analysis in 2024, this is European mostly. So only 75 or 77% were actually eligible and 23 were ineligible. That's their experience. So what is your experience in general? Nilesh, platinum, Indian patients, age group, is it different from the Westerners and therefore our platinum usage and all that? What do you say?
So this could be a referral bias based on my practice, but in my practice, almost 60% of patients are not platinum eligible.
60%.
It's probably because I'm seeing a lot more older patients, and just about 40% are platinum eligible in the metastatic setting.
Yeah, in the metastatic setting. Pooja?
So, sir, if you'll see the Galsky criteria, if we work in the real practice setting, any one of the criteria, if present, patient will be cisplatin ineligible. So, not only the ECOG PS, GFR, hearing loss, neuropathy, and especially the cardiac comorbidity all matters in deciding the patient fitness for the cisplatin eligibility. If we will see the real scenario, I found that only 30 to 40% are the patient on the cisplatin eligible, and remaining the rest of the patient, only 20-30 patient for carboplatin eligible, and only 10 to 20% patient are eligible for platinum ineligible patient. So these are the.
So what is your total platinum eligibility? You said around.
So around 40-50%.
40-50. So 50 are completely platinum ineligible.
So 40-50% are the cisplatin ineligible, and remaining 20-30% are the carboplatin ineligible also.
So if I can ask the chairperson, what is their quick thought on that? We'll move forward.
It's 50-50 in my practice.
50-50. Yeah. Amol, do we really do all these things? Audiometric hearing in all patients, peripheral neuropathy, grading and all that. Do you do, or you just rely on clinical history and then use it on the patient?
Ideally, we should do, but most of the time we don't do.
We don't do. Okay. So next question is, we saw that after a long lull, then came the immune checkpoint inhibitors. There was some initial enthusiasm that something is going to come out good with these one, but there were a series of trials with atezolizumab, pembrolizumab, durvalumab, or whatever addition of TKI. So all of them, we can safely say that they are all in the larger perspective later on, they are not really useful trials. Chandrakant, what happened? Why immune checkpoint inhibitors don't do anything in the first line setting in bladder? Is that a safe statement to make, or do you disagree?
So 4 negative and 1 positive trial. And
No, I'm just asking you to just discuss these trials before we move on.
So yeah, so I mean, IO in combination with chemo, especially if you have carboplatin as a chemotherapy backbone, it has not made a difference. So the chemotherapy backbone, synergism with the immunotherapy matters. So carboplatin matters.
So Dr. Lalit sir, why they didn't make an impact?
So I think, sir,
Is it because bladder is the nature of the bladder pathology, and what is your thought?
No, I think, sir, many patients, those who received carboplatin, they were itself very, like the biology was, the patient himself was frail, or he was unfit with comorbidities or with poor performance score. Second thing, there was a gap between the stopping the chemotherapy part and then starting the next line of treatment. So probably the disease has grown back in that waiting period. So this is what I feel.
Nilesh, your comment on the failure of the prior trials. That's
So
what I
while
want.
these are very highly immunogenic tumors, and therefore we would expect it to happen, I think the synergism with cisplatin and the absence of that synergism with carboplatin is the primary reason, and that is also the reason why eligibility for cisplatin is probably the most important indicator of treatment choice.
Why I want to spend a minute on this is that, one of the trials that we are going to discuss is generally a trial which has added an immune checkpoint inhibitor to the currently standard trial, and it is now reported as positive. So I want to really understand why would it be so. This new generation, it's not a new generation, new trial would be different, and so that's what I want to make a sense of it. And so these are the two trials that we are interested today, the Checkmate 901 and the EV302. And I believe the enfortumab data got DCGA approved just last week, I was told by the company, but it's not available in India. But I believe the 901 is still not approved by the US DCGA. Is that a right statement to make? Yeah, so not yet approved. So that's something that I just want to touch upon. And so platinum eligibility, is that how you decide, Dr. Amol? So do you look at the patient on, how the patient is going to be platinum eligible, not which platinum, and then therefore I choose the trial? Is that something that you're going to look at this?
The platinum eligibility of course matter, and the choice of platinum also matters. Those patients who are able to get cisplatin, probably, this has been shown previously also, and it was shown in 1992 that combos based on cisplatin are more active than cisplatin alone, and there is the data to show that cisplatin versus carboplatin, cisplatin does better. So choice of platinum eligibility, and amongst that if the patient is cisplatin eligible, does matter in bladder. But the criteria for cisplatin eligible, probably it is the only drug in which we say that if your PS is 2, we will not give. We don't say that about anthracyclines, we don't say about so many other toxic drugs. Of course, associated, it is not only. But probably you are very stringent or maybe very strict towards cisplatin, not towards the other cytotoxic drugs. But yes, choice of platinum does matter.
So why are we so strict about platinum, Dr. Chandrakant? Why are we so worried about it? The way to give infusion and all that, is that the reason, or?
So because here the site of tumor itself is the urinary tract.
Okay.
So a cisplatin can cause easily it can cause renal injury. So the only
many times they have already been operated.
Yes.
Many times there could be
and they may have one kidney if it
urinary
is
obstruction, so on and so
tumor.
forth. Routinely, many of them need stenting.
Yeah.
So
but
practical
so,
setting.
but if the creatinine clearance is between 50 and 60, so that is an area where I think I would push for cisplatin. I agree with the.
So Chandrakant, staying one more minute with you. This trial is the first one that we wanted to. Nivolumab plus Gemcis. So this is the trial design. I think it looks very simple and elegant. The comparator arm, and add one drug. So that's it, and then you continue it on monotherapy as a maintenance after 6 cycles. Both has been well balanced, and actually in this study, if you see that if the patient has difficulty in tolerating cisplatin, I think they can switch over to carboplatin also. So that's also allowed. So it's stratified based on PDL1 and the liver met. So design of the study looks very simple and elegant. Any comment on that?
Can you just go one slide back, sir?
Back, is it?
Yeah. One. So if you see the trial, of course, Thomas Powell is the PI of this trial also.
Yeah.
And for the Javelin 100 also, Thomas Powell was PI.
Yeah.
The Javelin 100 come much before.
Yeah, that's right.
It is his own trial. In his own trial, it showed that the Avelumab maintenance is good.
Yeah.
Then in the subsequent trial of his own...
He's an eminent...
That's what I'm saying. So the control arm should have maintenance, which is already proven. If you see the prostate cancer people, the Stampede trial or the Peace 1 trial, they have meticulously taken forward the previous approved therapies. So why not give Avelumab maintenance to the control arm and then show that your strategy is better?
Absolutely.
That is how the field will progress.
Yes. This study, I don't know when they designed this, but I think later on, as Dr. Senthil was pointed out, if only there could have been an ongoing, they should have thought about the comparator. Yeah, point taken. That would
I
have
think
really.
some did receive Avelumab maintenance. I think 7 to 10%.
No, we'll come to
Yeah,
that.
not
We'll
about
come to that. Lalit Shah, you're happy with the design?
No, I think same point here, sir. About the maintenance, the arm is weak, in fact, if you compare with the IO.
But can that be answered by one point that Avelumab is an expensive choice? Am I allowed to make that as an argument? And so therefore they wanted to go with the most standard.
Nothing is expensive to BMS.
Okay, nothing expensive. PMS. That's very yeah. So right, point taken. So, Nilesh, this is the PFS data. The PFS shows that addition of immune checkpoint inhibitors adds, few days of PFS benefit. So, what do you think about this PFS data, Nilesh?
So, I think this is what is being seen typically with many of the IO trials, that the PFS benefit, the magnitude may not be so much, but it's probably the one.
So, you're anticipating an OAS benefit later like many other, so you want to look for.
And that is probably what is driving the response also.
Okay. So, Sahoo, yes.
Yeah, the only point is when you look at the IO curves, the median is the word which is very important. We are looking at 1 point, that is a 1 point thing. So if you look at the curve, that things really gives the real picture.
So you mean the separation, that's what it's talking.
Yeah, because the median means that 1 point at the median point there was.
We're going to come to that in a minute,
Yeah. So basically what is the difference between this trial and JAVELIN 100 is that they have given additional 6 cycles of IO. That's the only difference. The maintenance is given in both the trials. So if you look at the first 6 months of additional 6 cycles of IO, which is given first 3 to 4 months, is there a difference? Probably there is no difference. Yes, it is a median. What it means is that there is a later on progression. So what it means is that probably the initial 6 cycles that you have given, which is the difference between this trial and JAVELIN 100, is probably not making much of a difference. There is not much difference in the median.
Yeah, we come to that point in this particular minute. This is the same. What is the magnitude with the overall survival? The overall survival magnitude is 21.7 months versus 18 months. And so 2.8 months median overall survival increment. So Dr. Pooja, are you happy with this OAS increment?
So although this is a very modest benefit of 3 months only, I'm not happy with that OAS benefit.
Hazard ratio of 0.78.
Yes. So hazard ratio of 0.78, basically as Senthil sir has said, this is a large peg benefit, not the Patiala peg benefit.
So it's not. It is a.
Yes, sir.
What I want to add is that if you see the previous 2 IO trials which have failed, if you see their OS hazard ratio, it is 0.81.
Correct. Yeah.
So it is 0.78.
Yes.
There is not much of a difference, ideally speaking.
Yeah.
So they were the same pegs. It is just that it has somehow become positive by what knows.
That's what I wanted to ask. When all the previous 4 trials, and this looks very similar, but has come out with the statistics on the right side of the regulator.
Sir.
Yes, Amish.
Sorry. Again, apologies.
Please.
All IO
Please
trials.
apologize.
All IO trials, if you see 50th percentile versus 25th percentile, you will see a seesaw difference. If you see the PFS curve in this particular, sir, how can we refute this curve? Why are we harping only on median? I still can't understand. Ever since the advent of IO, we are using IO based on its tail, which is separating, after 12 months, 24 months. And Amol, it's a conjecture. What you are saying is a conjecture that IO immediately has to work, while continuously IO has shown to work in a subset of patients and work for a longer time. And what Senthil also didn't say, he talked about conditional survival. Here,
No.
if you
Amish,
want to give.
Amish, I think what Amol was pointing out could be interpreted in a different way. Is it the maintenance Nivolumab that did the trick rather than the upfront addition? I think that's what he wants to say.
No, I agree.
The other
Sir,
point is that we agree your explanation of the median. But what I'm saying is that we would have been happy if we get a curve of like TDX1 versus TDM1,
Yeah,
which
of
we saw.
course, everybody
We
would be
have been more
happy,
than
but this is what we have. And
So
I
it is
think
like-
that this is
so-
like a
so I
Patiala
will-
pack
I'll give an
after
example. This is
12
like,
months.
This is like a marriage. Now you have got this wife, be happy with her, find out some good points about
No,
her and
I
live life.
don't agree.
It cannot be like that. No? You have always, in marriage you may not have an option, but IO you have an option.
Yeah.
Why did the 4 earlier trials not work and why did this trial work? What is the essential difference in this?
It is just by chance. BMS was lucky.
So, correct.
And maybe they did some, God knows, behind the curtain something.
So one point of maintenance versus concurrent. So you can have maintenance with the condition that there should be a response for the initial chemo.
Exactly.
So
I think
that is the whole point.
See, I mean, there is some logic. It's not that it is only they did a puja in the background like what Sahoo says. There is this you have seen. The response, the same thing can be said about the what Senthil showed, the Topaz trial. You immediately notice that the response rates were better, even though the upfront separation seems to be different, but the response rates are better with how do we explain that actually?
Of course, there are some
That
subset
is
of
real
patients-
data. Yeah.
There is some sort of subset of patients
Yes.
which have a delayed response. We don't know upfront what those subset of patients, but the same logic makes JAVELIN trial better because they have chosen those patients. They have chosen those patients who are showing response, and then they are giving maintenance drug. So you are upfront not exposing everyone to everything. You are choosing the one who are responding, and then you are trying to see how it becomes better. I think that is a better strategy rather than giving everything everybody and then say that, oh, now somebody is working. Unless you have a clear-cut biomarker.
Yeah, I don't know whether I will completely agree with you, even though I take up your point that whether the maintenance part of Nivolumab helped and Avelumab maintenance in the comparator arm would have been a gold standard result, so to say. I'll come to you in a minute. This is what has actually happened in the patient. Only few of them did receive
Only
Avelumab.
20% before progression have received IO and 20% have received after progression of IO. It is a subsequent
So in a
therapy also.
way, it's a Puriton trial in which it's only the Gemcis and then addition of a third drug. That's what was compared, even though we think that the comparator was not a gold
Post-progression therapy is also suboptimal.
Sir, what was the disease control rate for both the arms?
standard. You have the overall response
No,
rates
sir,
here.
my point is JAVELIN, if I am not wrong, the PD were not done. Rest all went on to use the Avelumab.
Yeah,
So the DCR will be the main thing, not the response rate. Even the stable disease went on to receive Avelumab.
Correct. Okay.
Yes.
Yeah, so that's what I'm
JAVELIN had a
meaning to
super
say.
selected group of patients who already had a good response.
No. who
No.
did not
He's
progress,
pointing about the stable disease patient.
who did not progress.
Yeah.
It's not a response.
That was the Avelumab
So
design.
the advantage of this regimen is you have more number of patients going into maintenance. With Gemcis
No,
one.
I'm not. You're not getting a point. If the DCR is same for both the arms, then did induction chemotherapy make a difference? That we can answer.
It is not probably making a difference. And if you see, of course, sir will probably show, if you see the JAVELIN is in all populations, cisplatin and carboplatin both. If you see JAVELIN's data of only cisplatin, that median OS comes to 31 months. Of course, the duration of follow-up is different from JAVELIN and the data of the Checkmate is progressing.
Yeah.
But right now it is at 21 months.
Yeah.
Maximum it will go to another 10 months.
Yeah.
So whatever said and done, it is not
Amal,
going to beat.
We'll come to that. So I'm not going to take too much time here. Obviously, addition of one more drug, little bit more to the grade 3 toxicities. I think this is not the one that is going to cut the clinical decision later on. So you need to learn to manage. That's all. But this is one other issue about this Checkmate 901. This was the original design. In which this was earlier published in 2020 itself, and this was cis-eligible and ineligible patients. In patients, even in cis-eligible and ineligible patients, there was a doublet arm earlier, and then this is the other sub-study. that the upper part, that primary study is not reported. It's completely background.
So whatever that is
It's
negative
gone.
is only given as a press release by BMS, and nobody talks about it.
No, there is a press release already.
That's it.
That press release has shown that they did not meet the primary endpoint. So they left it there from that point. This also includes cis eligible patients and ineligible patients. That is completely, that's gone, and the other subset is taken for further analysis. So we will leave this trial for a minute here, and then we'll move on to the next trial. We'll come back later on to put both them to the SWOT. This is the updated report on the maintenance Avelumab. So as you know that originally it was reported in 2020, 2019 and 2020, and this is the more than 2 years of follow-up after the JAVELIN JB100 trial. So you are all very, very familiar with the JB100, and probably in whichever affording patients you are already practicing this. So this was, really harping on the maintenance point of Avelumab. The trial essentially was median overall survival was 21 months versus 14 months, and the PFS was 3.7 months versus 2 months. So that's the core data. Then you follow it up for further 2 more years, and that is 19 months plus from the original analysis, and this is now reported as the updated. This is the trial design in essence, and the point is that this is the comment. Updated analysis are considered exploratory, and all p-values are descriptive. So what is your comment? Dr. Chandrakant, we talked about it in the previous discussion. So
no, it is important to report the updated analysis. Yeah, so it is important. So it is good to report, and it is always good to mention that it is exploratory. It's well acknowledged.
That's right. So 19.5% of the patients received more than 2 years of Avelumab. That is the reality of what happened with this patient. So does that impact this less than 20% people have received Avelumab more than 2 years? Do you think this is just a reality reflection, or that's going to make you think again? What do you say, Amal?
See, if you go to the previous slide, sir, what they are trying to show is that, sorry, our numbers at the end of these 2 years are very less, so don't expect too much into the p-values and all. But that is fact with most
That's
of the
a fact
trials.
they mentioned, yeah. So I'm asking, only 19.5% of the patients received Avelumab for more than 2 years of Avelumab treatment. So
of course, it is no drug is an easy drug to give in a bladder failure.
So that's just a reflection. Nilesh, what is
So
it?
the other thing that is also important is the median duration of Avelumab was only 5.8
5.8 months. Yeah.
So it is again that 19 or 20% that is driving all the benefit on the side of Avelumab.
So the updated analysis, shows that the median overall survival has slightly improved from 21 to 23.8 months, and even in the comparator arm, it has come from 13 to 15 months, and the hazard ratio still remains more or less the same, 0.76. So this is the update OS, and so the risk of death with the long-term follow-up, you really have a risk of death reduction by 24%. So with this update, are you now fully happy with this, Dr. Nilesh and Dr. Pooja? What do you say with this update?
So I am as happy as can be, because like I said, we are still not able to identify which of these patients are really going to benefit. Because at the end of the day, we understand, similar to other IO trials, maintenance trials, that there is a small proportion of patients who are going to benefit. Does the drug work in this maintenance setting? Of course it does. Unfortunately, we can't.
Why would you say that? As Sahoo pointed out, this trial was designed that the patient should have a CRPR and a stable disease selected. And that platinum sensitivity, or at least the stable disease, is the selection point. That's how they have designed it.
So coming back to what Amol said, since the difference at the median wasn't very large, this probably is a better way of treating this group of patients rather than using it upfront.
Okay, can I add?
Yeah.
There is a, see, what ideally everybody will want is that you first give to whether the second line drugs they work better if you give at a later part. So there is a real world data called as a United study.
Yeah, we're coming to that.
Okay,
Coming to that. Just we'll come to that. So the another way of looking at is again the overall survival of the JAVELIN data is that first line chemotherapy with full JAVELIN is the median overall survival is 29.7. This is with from the start. So will that be now with the 901? Is that one more way to look at the JAVELIN data instead of from the time when which the Avelumab or from the beginning? So is that a right way to look at it actually?
For the treating patient, when you explain the data, you have to explain from the day one.
From the day one. Okay. So you agree with that kind of a viewpoint, correct?
No, but those patients who have not progressed, only they are included. So you are not including those patients who progress. So you cannot take from day one because those who have progressed are not included in JAVELIN. So that number may not be Gemcitabine Nivo number. That is what I feel.
See, we follow the same strategy in say breast cancer also. Those who respond, we continue the same. Those who don't respond, we change to TDM1. That is what has been done in breast also. So many other cancers. We want to choose good biology and give them the more benefit. So the bad biology required different drug, more stronger drug.
So what Amol said the last sentence, in fact, Tarini and I, we were just looking at the NEJM paper of Nivolumab and your talk about good biology and bad biology. In JAVELIN 100, only good biology was selected for maintenance. But if you see, sir, we have the table in front of us. The complete response with addition of Nivolumab was doubled, 11% to 21%.
Yeah.
In Nivolumab arm, 1 minute, Amol. And this
901.
complete response, median duration of this complete response is 37 months versus 13.2 months in the only chemotherapy arm. So you are making some of the bad biology a good biology by addition of Nivolumab upfront compared to maintenance. I think this you cannot deny, and Tarini also had a point about the cisplatin and carboplatin.
Unless,
again,
can I answer that?
Yeah,
Major,
sure.
from my point of view? Unless until you have a trial in which there is a induction, 6 cycles IO followed by maintenance versus only maintenance head-to-head trial, you cannot say what is the contribution of the initial 6 cycles and what is the contribution of maintenance. The same way it is done in the lung cancer. Nobody knows what is the contribution of neoadjuvant versus adjuvant and whether what is the correct strategy. So
all of
we
us
don't have that
accept
answer.
that maintenance is here to stay in your bladder. That's taken. Yes. Okay. So how do you take more patients eligible for this maintenance? I think the concurrent addition of immunotherapy to chemotherapy has done 2-3 things. It has added 15% more to the kitty. So even look at it, the progressions were less, the CRs were more, the stable disease was similar. So you had a 15% more patients who were eligible for maintenance. And if you can get that 15% more, I think that is done. And about the trial which are negative, there's exploratory analysis for both the trials with Atezo and the Pembro, again quoted in this article, when they looked at patients in that trial which took cisplatin and carboplatin. That is why the change was made. And if you look at it, patients in both the negative trials, when the exploratory analysis was done for cisplatin only, they became positive for OS and PFS. So point to be taken, what we should take back, what I have taken back is, do not shift to carboplatin because of your convenience. Stick to cisplatin if you are using immune checkpoint, and addition of immunotherapy to the induction protocol does make a difference because making more patients eligible. Last, you have a finite number of cycles to give 2 years. I would not go beyond 2 years.
So are you making a statement, Sahoo, that the addition of immune checkpoint inhibitors at the upfront, as the response rates have shown to be, so that's where it's really acting, that it is converting a bad biology into good biology, response rates have gone up. Is that what you are trying to finally say?
Can I put a point,
and
sir?
also not so good biology, they're making it respond so that they are able to get a immune checkpoint maintenance which otherwise they would not have got.
So what you are saying is that the cisplatin carboplatin point is well taken. What you are saying is that you have, Dr. Sahoo, you are saying that, you yourself said that, by giving additional 6 cycles, you are benefiting 15% patients. That means you are not
more.
15% you are converting.
More than who would not have otherwise got a maintenance.
That means the remaining 85% are not getting any benefit.
So if I can ask,
Additional 15% more, right?
By
But for that, you have, unless you have a biomarker, you cannot say that
Amal,
to give it to everyone.
by that argument, if you select responders, good biology, then we may be giving unnecessary treatment to them by continuing on maintenance. Yeah. So you can't have both the sides. You can only think of one thing.
So anyway, staying on. So Senthil, you wanted to say something?
Trying to tell him that though 15% get better, that is not reflected as lack of events on the Kaplan-Meier. If you look at the Kaplan-Meier for 901, if PFS, not the OS.
We're coming to that, yeah.
I'm sorry I was not there.
We did talk about this.
So you look at the Kaplan-Meier, 6 months, they're sitting on top of each other. So if what Sahoo and Amish are saying is true, it should start separating very early.
No, we talked about that.
No, I'm just saying that.
This is.
No. So let's not get into the number of risks. So look at the Kaplan-Meier there. So it is sitting on top of each other, which means
179 still did not have event, and 11.
No,
Senthil,
okay, I'm not
Senthil, you know what happened in the few minutes that you were away is that. See, each one wanted to, same thing, each one wanted to draw something out of that. They said the early separation is not there, so therefore adding upfront was not a good idea. Maintenance is where the trick is. That's one argument. The other argument is that this improved the response rate, and therefore something is happening. So the upfront treatment is too. That's the second thing. And you are trying to put both together and say that. So what is that you are saying now?
So I am saying that the responses, additional responses, are not really translating into events. So you let's say somebody's got stable disease. You're still okay with that.
Yeah.
You also should look at the number of complete responses, which is unusually high in this study compared to what you get in certain other studies. So we may attribute it to cisplatin, but the fact still remains that it is unusually high compared to what we get in the others. Of course, the EV Pembro is much higher than this. That's about 30% complete responses. But though I agree with what both of them are saying, my point is that it's not really translating into improvement in events. That's all. That's the point I'm trying to make.
So would you want to say that then?
For me, personally, the maintenance strategy seems to be a better strategy rather than induction strategy. That's all I'm saying.
Yeah. So one more thing, does any of this explain the usual phenomenon that the PFS is not different, but the OAS is different in many of the immune checkpoint inhibitors? Does any of this explain biologically to where we get
that stands true when you're using only immune checkpoint inhibitor. Whenever you're using combination, you will almost find that the PFS is better, the OS is also better. So that happens because it takes longer time for the response to kick in. So some of the patients are lost in that time. So you see that the PFS.
Again, thank you. Again, I'm not going into the adverse event. It's addition, and that's fine. Only good thing is about.
And also, sorry to again interrupt. I hope you have discussed this. Again, if you look at the hazard ratios, it's again cross-trial comparison.
Correct.
All accepted. Hazard ratio is better for Avelumab. Numbers, you showed that just now 29 months versus if you add the previous 4 to 6 months also along. So if you do a cross-trial comparison, for me, I think if you choose a set of patients and treat them well, makes more sense compared to putting it on everybody and then, I'm not saying that's a wrong strategy. I'm saying for me, the maintenance strategy looks to be a better strategy.
We are going to do cross-trial comparison, but unfortunately, I didn't bring the HR as I could have done that. So, but yeah, so this is the basic differences between. The only thing is that in the JAVELIN data, 8 out of 10 patients were deemed as eligible for platinum, whereas in the Nivolumab data, it is 5 out of 10 patients. Otherwise, Indian patients, fine. How many of you want that as a specific criteria? And again, we already discussed that Avelumab maintenance did not reach a significant proportion in the comparator arm in the Nivolumab study. Therefore, it is a Puriton chemo only comparator arm. That's what it is. So this is not exactly a cross-trial comparison of the hazards ratio as you are pointing out, but this is some sort of comparison actually.
And I also think the Avelumab study is more inclusive, it's more real world, because not everybody is going to be able to take cisplatin. So if you want to use Nivo, it has to be cisplatin, and when I was there for the initial part of the discussion, people ranged from 30% to 60% being cisplatin ineligible.
So can you explain why it should be cisplatin if I have to use Nivo? Why? Can you explain that point alone?
The interaction, so it is supposed
Where
to.
is it? Where is it proven that there is an?
That's the point.
I have never
That is exactly the point. So there is always still a dispute in the urology world as to whether carboplatin is actually inferior or not. Because you will always see that the sicker patients go on carboplatin.
That's fine. That we know, but you made an addendum to that. That is the patient that's going to respond well to Nivolumab.
Because that's the trial inclusion. That's the trial inclusion.
No.
And he also said that the subset analysis of the previous studies where the concurrent ones failed showed subset analysis of cisplatin being positive. So that
is there an explanation why this platinum or that platinum would do good with the immune checkpoint inhibitor on a biological basis? That's what I'm trying to ask.
There is no explanation on biological basis.
There is no clear explanation.
There is no explanation.
Cisplatin is working better.
So as always, you have to explain what you found.
Yeah.
So the explanation for what you found is that the immune checkpoint inhibitor is better with
we need some
So,
more
but if you look
explanation
into
to do.
Avelumab maintenance, carboplatin did better. Like the hazard ratio for Avelumab maintenance.
No, it's despite the platinum, it is.
No, sir. So if you look into GEM carbo subgroup, the hazard ratio for Avelumab maintenance is better. So Avelumab is doing better with carboplatin as switch.
That is.
No, I don't think you should come to that conclusion.
Switch. As a switch.
That is convenient. I don't know. So
Hazard ratio
this is the enfortumab data set. Quickly, we'll do justice to this important trial that came this year. This is another, again you point, this is also Dr. Paul's, everywhere it's Dr. Paul's. So he could.
Now who to blame?
He could have done the Avelumab. This is a trial in which he could have done, a maintenance Avelumab. That's that in which I completely.
80% of patients in this got immune checkpoint inhibitor later.
Not 80%, not 80%. No, not 80%.
One is only 40%, 20 before progression, 20 after progression. That I have written the numbers.
So anyway, this trial is very important because again you see a very early separation of the progression-free, and look at the hazard ratio of 0.45. This is much bigger than your Patiala and whatever you can call this. Even the overall survival is whether you want to call it as whichever hard liquor or a soft liquor, it is still a very, very big, very and adverse event about enfortumab, we are learning, it's a difficult drug, so I'm not going to delve. That can be always, but this is an important point, QOL, so that makes an impact. A quick thought about enfortumab, any of you, Amol, what do you say?
It is a good combination. If given upfront, it is working well. But at the same time, we have to look at the sequence also. And yeah, the retrospective data is presented in this ASCO-GU about the United data. And probably if you give JAVELIN strategy followed by EV on relapse, and you add up those numbers and do cross-trial comparison, which should not be done, probably we are in the same range, not very different. Because we don't have anything to back up as of now to the EV plus Pembro as of now. And that's what I always say, if Tendulkar bats first, who's going to bat later?
So if I may ask you a general question, Amol, because you wanted to ask many questions to Senthil. Usually in a given data set, when it's all published in black and white, why there are very different takes on the same final analysis? Do you have a guess on why people take it so differently? Is it belief, intuition, and finally their own experience? What is your quick take on this?
It's probably the combination of everything.
Okay.
And because most of them try to look what is, say, as I said, the information.
So you want to say that people look for what they want to look for?
No, it's
why a single data set is interpreted among the learned audience in a very different way?
There is no transparency in the data. If there is a transparency in the data, it is not what you say as black
and white. Is that the only
reason?
reason?
Most of the time in grey. That is the whole problem, sir.
tumor. It is, the beauty lies in the eye.
50 shades of grey, sir.
I had a comment about the platinum ineligible patients.
Right.
So those who are going to be getting carboplatin-based therapy,
Yeah.
it's very unlikely that many of these are really going to go to second and third line. And in this group of patients, I think the best drug forward would probably be the best option, so long as it is tolerable. We understand that nobody has used this drug. At least I have not used this drug.
Yeah.
But given a chance, then that will probably be the best.
Nilesh, since we are running out of time, this point, the overall survival has really improved over a period of time with all these intervention. Just going back to the JAVELIN data, if you just look at the overall survival from the start of we touched upon that, from the start of the platinum, so that looks even more better, and it is very close to the EV data. So I'll begin, Dr. Pooja. So this way of looking at JAVELIN 100, is it acceptable or not acceptable?
Sir, I think this is certainly a acceptable thing. For EV plus Pembro data, I feel that we should not omit the chemotherapy in the first line. We should combine the chemotherapy, especially with maintenance Avelumab. For chemotherapy with Nivo, I'm not sure, but certainly with JAVELIN data, I'm very confident.
Nilesh, are you comfortable with this way of looking at this data?
So no, I'm not comfortable.
You're not comfortable.
Because that is a separate group of patients altogether.
Lalit sir?
Comfortable, sir, but if we can have some more biomarker and we can have the much more benefit with the maintenance.
Biomarkers, Chandrakant, none of the bladder trials have been, biomarker helped out,
In
so
fact, some ctDNA and all that is still in pipeline, in fact.
now one other issue with the bladder trial is what happens afterwards. What happened? Does that influence you, Dr. Chandrakant?
So exactly, sir. So like we have 3 important drugs. Like one is platinum, number 2 is IO, and number 3 is enfortumab. So these are the 3 things that we need to put in sequence. So whether we can omit platinum in the front line, if the disease burden is high and where I cannot afford progression at all, and the patient is only carboplatin eligible, there I would probably use enfortumab vedotin plus pembrolizumab.
Amol, do you think about sequence when you see your patient? And the other important thing you pointed out, I'm taking only one more minute. So the real world data, fortunately because JAVELIN came some years ago, so there is always a real world data. And there is now a good strong real world data. This is what you pointed out, the UNITE data when you switch maintenance and enfortumab afterwards and sequencing. So my question to you is that, so sequencing and real world data available, does that influence you?
I will discuss the data with the patient and let the patient choose, which is the standard answer acceptable for everybody. But in my own mind, I will go for sequence rather than.
The last question is, as you know, this is NCCN recommendations, and as Senthil was pointing out, most of the time the recommendation is not just based on the numbers on the data also. It's the NCCN recommendation also includes availability, access, and several other things. That's how the recommendations are done. So how sacrosanct, and to question to you, Dr. Senthil, is that when you presented your arguments on Holy Grail, the problem is there is a patient, there is a doctor, but finally there is an arbiter somewhere outside. When there is a trouble, there is somebody to judge, and they don't look at all those very, very important but subjective elements that we talked about. And that time you are alone. You are completely alone on your own. And so where do we stand with that? So guidelines and all that, but we are alone, we are standing the judgment.
I know, I don't think there is a good answer to that question, because we, in our best intention always, do the best for our patient after discussing the pros and cons as much as our knowledge and judgment would permit us to. But I don't think that ensures us of being out of trouble, is what I would think. If you're destined to be in trouble, I think in spite of the best precautions that you take, you will be in. But I think we should do the right things to make sure that we are not caught on the wrong foot. You may still be, but I think we should do our best not to be on the wrong side. That's all that I can suggest.
I think it's a suggestion. Then thank you so much, all the panelists. Thank you.
So sometimes we write things like this. The slide said thank you, and at the bottom it was meant for healthcare professionals only. So Hemant, now may I request you to please give your expert comments.
So thank you very much for this opportunity, and thank you everybody for hanging on, and wonderful moderation of the panel discussion by Dr. Raja, and extremely insightful and excellent inputs from the panelists and the audience. So I'm, what should I say, ancient conservative oncologist, and cost considerations and benefit scales are extremely important to me. I have seen young colleagues use immunotherapy in patients for a few months of benefit, patients having to sell their land and property and cattle, and the next generation also being improvised for no benefit or for 1 or 2 months of benefit. So my inputs will be from that perspective. The first study, the NEJM study, a benefit of less than 3 months. Again, as Dr. Senthil pointed out, it might be vital for one single particular patient to have 2 months of extra life, and it has to be weighed with the costs which the patient incurs. Again, I think one of the most important things which we are still lacking for in immuno-oncology across the board, across all drugs, is that our science of the predictive markers is still primitive. We know that 2 or 3 out of 10 patients whom we intervene with will respond. 6 or 7 or 8 out of 10 will not respond. So we have to improve our predictive science so that we can get to at least 50%. I mean, you can't ask the patient to spend 8-10 lakhs of rupees and after 4 or 5 cycles then tell the patient, sorry, this expensive intervention is not working for you. So I think people are working on that. People are developing an immune score. There are enough patients worldwide to provide a large enough database. And as what is Dr. Parikh's favorite buzzword these days, use artificial intelligence to pick out prognostic factors. But let's hope we get to that soon and we refine our science of predicting which patient will respond. The second trial, I think there is level 1 evidence for that. And just by the way, for the NEJM trial, even the NCCN, which is I think a little advanced in giving approvals, which again Senthil pointed out, the level of evidence is 2A even by the NCCN. The other trial, the maintenance Avelumab trial, the level of evidence is level 1. But again, the 24 months versus the 36 months, I think all of you must have noticed that the delta has reduced. We would like to see the curves to separate further. We would like to see the curves, at least the separation to remain the same. But at the moment, it looks as if in another year or in 2 years, the curves will overlap. Then you also have to keep in mind that once the patient starts progressing, that might be the time to add the immunotherapy. So that is another option. You select the good biology patients, don't give them additional toxicity, additional expense. And when the patient progresses or the patient has, as per progression, a bad biology, then you add the expensive intervention. So that is another strategy which needs to be thought of. I don't think they'll do trials and compare that. But these are my inputs. Of course, immunotherapy is the advance of the decade, no denying that. Other than Hodgkin's lymphomas and maybe RCCs, across the board, we are benefiting out 2 or 3 out of 10 patients. So again, we have to choose our patients very carefully. This is an expensive modality of treatment, possibly out of reach of majority. We should not push the patient into poverty for 2 or 3 months of benefit. So that is my conservative assessment of these 2 studies. And thank you very much again.